In the last class, we discussed regarding the synthesis of glycine and also of the glycine has been broken down, right? In today's class, we're going to discuss regarding what are the special products formed from the glycine and what are the disorders associated with the glycine metabolism. What is a major metabolic role of glycine in our body? If you see, there are various products that has been synthesized from a glycine. We'll see one by one. So if you see, first one is the formation of creatine phosphate, and creatinine. And next, uh, heme can also be synthesized from a glycine, and purine nucleotides, glutathione, inhibitory neurotransmitter, and conversion to the back to the serine. And we have seen in the last class where how the glycine has been synthesized from a serine. Same way, the serine will be converted back to the glycine, and also conjugation of bile acids, detoxification of benzoic acid to the hippuric acid, and contribution to one pool in glycine cleavage system. In the last class, we have seen how the glycine cleavage system is done and how the methyl group that has been donated to the tetrahydroxyfolic acid to form methylene tetrahydroxyfolic acid. It means that it is donating one carbon atom, so it is involved in the one carbon pool. So if you see the first one, the synthesis of creatine and creatinine from a glycine. So you can see here the amino acid glycine combined with the another amino acid called as arginine. You can see the structure here, the structure of a glycine and the structure of a arginine. Okay, so the enzyme involved in is glycine arginine amidose transferase. You can see here this is called as an amide group. So what is an enzyme here? The glycine arginine amidinotransferase. It means that the amide group from the arginine has been transferred to the glycine. Okay, then it forms as guanidoacetic acid. What it forms? It forms as a guanidoacetic acid, and rest this structure is called as ornithine. So this guanidoacetic acid further converted into the creatine by enzyme guanidoacetate methyl transferase. So what is an enzyme? Methyl transferase. It means that methyl group has been transferred to the guanoacetate. Now who will donate that methyl group? That is S-adenosine methionine. It's an active form of methionine where when it donates one methyl group to the guanidoacetic acid, it forms as a creatinine, and the rest, this S-adenosine methionine is converted to the S-adenosine homocysteine. It means that one methyl group has been lost, right? So it forms as a S-adenosine homocysteine. Again, this creatine, again, by the enzyme creatine kinase. You have seen it whenever there is a kinase, so it means that we require ATP. So the ATP has been converted to ADP, and this phosphate group has been taken up by the creatine. You can see here, right? Here there is no phosphate group, but there is no phosphate group is added by the ATP. Okay, and form as creatine phosphate. And again, by the spontaneous and non-enzymatic reaction, one phosphate is lost. Okay, and form as creatinine. It is the difference between creatine and creatinine. Okay, so this forms as a creatine, and this creatine is excreted from our body. So this is a synthesis of creatinine from a glycine. Now you can see the various, the enzymes present in the various organs. If you see the first enzyme, the amidinotransferase, it is present in the kidney. Aminotransferase is present in the kidney, and this methyl transferase present in the liver. So it means that this gonad acetate has to go to the liver for, okay, and these to convert into the creatine, and these again, right, this creatinine has to go to the muscle because the creatine kinase is present in the muscle. Again, this creatine phosphate is spontaneously converted into the creatinine in the muscle, and this creatine is excreted into the urine. Okay, that is about the formation of creatine and creatinine. Now, what are the clinical importance of this creatinine phosphate? Now, you have seen here, right, the creatine phosphate. The creatine phosphate is a high energy compound, and it is stored energy present in the muscle. So why it is called as a stored energy? So right, when the ATP has been utilized, it forms as ADP. So this ADP, whenever we require energy, the creatine and phosphate donate one phosphate group to the ADP and forms as ATP. In the presence of enzyme creatine kinase, remember the creatine kinase, this ATP used for the energies for the muscle. So as it is donating the phosphate group to the ADP, it means that the phosphate group is present in the creatine. So it acts as a stored energy present. So it is one of the high energy compounds. And this creatine kinase is an isoenzyme. Okay, you could have studied this isoenzyme in the enzymes chapter. So as it is a isoenzyme, so there are three types of isoenzymes of creatine phosphate. One is present in the muscle, one is present in the brain, and one is present in the heart. So in the muscle it is called as CKMM. That is, it is elevated in a clinical conditions called as muscular dystrophy. And CKMB, where it is elevated in a clinical condition called as myocardial infarction. So that is about the creatinine kinase. Next, what is the importance of creatinine? So normally it is not seen in the urine and increased in the muscular dystrophy. Dystrophy means that the muscle is not meeting to the proper and muscle diseases. And normal serum creatine level is around 0.2 to 0.4 mg per deciliter, and I already told you it is increased in the muscular dystrophy. The rhythm in dystrophy, the rhythm of a muscle is lost. Dystrophy means the rhythm is lost. And in the serum creatine, so if you see the serum creatine, the normal levels is 0.7 to 1.4 in the male and 0.6 to 1.3 in the female. The less amount of creatinine in the female is due to the less muscle mass, because the male has more muscle mass when compared to the females. And serum creatine levels are increased in the renal disorders. And creatine clearance test is a test for the glomerular filtration rate. It means that if you want to check the GFR, one of the tests to identify the function of a GFR is a creatine clearance test. Next is the synthesis of heme. So how the heme has been synthesized. So glycine, glycine combined with the succinyl CoA and form as delta ALA. This is the first step in the heme synthesis by enzyme ALA synthase enzyme. So it means that without the glycine, there is no further reaction form. So it involved in the heme synthesis and is also involved in the synthesis of purine ring. So glycine contributes the C4, C5 and N7 of a purine ring. You can see the which is purine structure, the different contributions of purine ring. So you can see the sixth carbon is from carbon dioxide, the first nitrogen is from aspartate. Likewise, the fourth, fifth, and ninth N7 of purine ring is contributed by the glycine. You can see here one nitrogen, one carbon, and one carbon from a glycine. Next, conjugation with the bile acids. So bile acids. So glycine conjugates the bile acids to form glycocholic acid and glycosinodeoxycholic acid, and this is catalyzed by the enzyme glycine acyl transferase. And it also conjugate with the benzoic acid. This benzoic acid is harmful for our body, so it has to be excreted from our body. So these glycine combined with the benzoic acid and form as hippuric acid, and these are excreted in the urine. And the enzyme catalyzed are, there are two enzymes, one is benzoyl CoA synthase and the next one is glycine and acyl transferase. These both involve enzymes involved in conversion of benzoic acid to hippuric acid, and this hippuric acid is easily excreted from the urine. And next is synthesis of glutathione. You could have studied this glutathione in the amino acids metabolism. Where what is this glutathione? Glutathione is made up of three amino acids, that is gamma, glutamyl, cysteine, glycine. Means that glutamyl group, cysteine group, and glycine. These three combine to form a glutathione. So glutathione is one of the antioxidants, right? And also this involved in the amino acid transfer. This cycle you have seeing here is also called as Mister cycle. For cycle it is called as Mister cycle. You can see here the amino acids coming inside by enzyme gamma glutamyl transferase. It is taken up by the glutathione, where it splits into two. One is cysteine glycine and gamma glutamyl amino acid. This amino acid is being taken inside. Again, the glycine and cysteine combine in between and forms as a glutathione. This is called as mystery. I mean, Mr. cycle, and this is so glycine is one of the important factor to synthesize the glutathione. You can see here the glycine combined with the glutamyl cysteine to form as a glutathione. And glycine is also a constituent of a proteins. So if you see the extracellular matrix, the collagen, if you see the collagen, so these collagen, every third amino acid in the collagen is made up of a glycine. So 33% of the amino acid in the collagen is made up of a glycine. So it is one of the important constituents of a extracellular matrix protein, that is collagen. And that is all about the important protein synthesized from a glycine. So next we will discuss about the disorders associated with the glycine metabolism. The first one is non-ketotic hyperglycinemia. What is this non-ketotic? It means that there is an increase in the glycine in our body. That is glycinemia. Anemia means in the blood, glycine in the blood. Okay, increased glycine in the blood. Hyper means increased. And non-ketotic, it means that there is no formation of ketone bodies. So this is due to the defect in enzyme glycine cleavage system. We have seen the glycine cleavage that how the glycine has been cleaved, right? So the glycine levels in the blood will increase because as the glycine is not cleaved, ultimately it is accumulated in my body. So it leads to increased glycine level and in the blood, the urine, and also in the serum, CSF. So cerebral and several mental retardation and seizures are seen in the patients with the non-ketotic hyperglycemia, and there is no effective management, and diagnosis can be done based on elevated levels of CSF and blood glycine ratio. And hyperglycemia is also seen in various organic acidureas. Next is glycinuria. What is this glycinuria? Glycine in the urine. So I mean, we can see the glycine in the urine. So it is an autosomal disorder and it is defect in the renal tubular transport. It means that the transport of a glycine in the renal tubular system is affected where the effective reabsorption of a glycine is not proper. So there is a common transporter for a glycine, proline and hydroxyproline. So these transport is being affected so that glycine, proline and hydroxyproline are seen in the urine. It is a benign condition although some patients show some symptoms like encephalopathy, blindness, deafness, mild mental retardation and some kidney stones. That is about the glycinuria. And next is about type 1 primary hyperoxaluria, and this is the most important question and mostly asked question in the exam. So what is this primary hyperoxaluria? So that means the primary means it is a main cause, and hyper means increased, oxaluria means oxalates in the urine. So increase of oxalates in the urine is called as hyperoxaluria, and this is due to the protein targeting defect. What is this protein targeting defect? So you know that after translation, the proteins has been synthesized. Okay, I mean, the protein synthesis will takes place after transcription. There is a translation. So when the proteins has been targeted to the particular place, but due to some defect in the targeting, these proteins are misplaced. So example, the enzyme, I mean not example, I mean what about the primary auxiliary, the enzyme alanine hydroglycoxylate aminotransferase, okay, is located in the hepatic peroxisomes. So where should exactly it is located? This alanine and glycoxylate aminotransferase has to locate in the hepatic peroxisomes, but it is seen in the mitochondria. So the enzyme position was only different. So that is, it has to present in the hepatic peroxisomes, but instead of presenting in the peroxisomes, it is present in the mitochondria. Ultimately, the enzyme will become inactive because the position has been lost, right? So you don't know. So it become inactive. So the enzyme become inactive. So the degradation of glycoxylate will not occur. So glycoxylate cannot be degraded. So ultimately what happens is there will be accumulation of glycoxylate and oxalic acid in the body. So up to 600 mg per day, and normally if we see the glycoxylate it is 50 mg per day, but it is made up to 600 mg per day. So these oxalates are deposited in the kidneys and leads to nephrolithiasis, renal colici, and hematuria. And due to the early occurrence in the early stage renal disease, a chance of survival is very less. And extrarenal oxalasis is that extrarenal means the other than the oxalate, I mean, other than the renal, I mean the stones can occur in the heart, blood vessels, and also in the bones. So you can see this is about the metabolism of a glycine where conversion to glycoxylic acid. You can see here the glycine can be converted to glycoxylic acid. This glycoxylic acid either can convert to glycoxylate and oxalic acid. And this glycoxylic acid again can convert back to the glycine. But what's happening here? This enzyme is deficient. We have seen in the last slide. So as this glycine glycoxylate amino transfer is deficient, this will convert into glycoxylates and oxalic acids more. That's why this oxalic acid and glycoxylate will accumulate and forms to the nephrolithiasis and urolithiasis. Next is about type 2 hyperoxaluria. It is due to a defect in activation of cytoplasmic glycoxylate reductase. So you have seen there, right, in the last one, the glycoxylate reductase is deficient and it is a milder condition causing urolithiasis. So what is the major difference between this urolithiasis and nephrolithiasis? The urolithiasis is commonly known as a kidney stones, refers to the formation of hard deposits made from minerals and salts within the urinary tract. And within the urinary tract, these stones can be developed in the kidney, ureter, bladder, and urethra. But if you say nephrolysis, it's only in the nephron. It is been affected. So what is the management? So intake of water, mean high increase intake of water so that the oxalates can be excreted in the urine and minimize the dietary intake of oxalates because already oxalates has been accumulated in our body. So these oxalates are present mostly in the leafy vegetables, tea, beetroot and all. So restrict the intake of leafy vegetables, tea, cocoa, beetroot and spinach can minimize the formation of oxalates. This could be the effective management. So these all are the references which I took. So I think you understood about the glycine metabolism, where we have started with the in the last class we have started how the glycine has been synthesized and been broken down. In this class, what are the products formed from the glycine and what are the disorders of glycine metabolism. Thank you.